Now, the next topic is about metastatic bone disease and pathologic fracture. It's very common in clinical practice for general orthopedic practitioners. Metastatic bone disease is the most common malignant bone tumor. It's by far more common than in primary bone sarcomas, particularly in middle and elderly age population. Bone is the third common organ to be affected by blood-borne metastasis after lung and liver. In 5% of cases, the primary site is unknown and it's called ectopic primary. The most common carcinomas that send hematogenous spread yearly is cancer breast, followed by cancer prostate, then follicular thyroid cancer, small cell lung carcinoma, renal cell carcinoma, and in Egypt, hepatocellular carcinoma. Stages for metastasis is first the cell property to escape from the primary carcinoma site is via genetic influence and chemokines that induce tumor-induced angiogenesis with a poorly formed blood vessels, weak basement membrane, metalloproteinases to invade the basement membrane, and the tumor cell to be inside the bloodstream. To survive within blood circulation and to escape from the immune system via modulation with the major histocompatibility complex. The affinity of tumor cell to settle inside the bone is via endothelin and chemokines produced by the bone matrix. After the tumor cell be inside the bone, there are two stages, either stage of dormancy in the form of micrometastasis and with unknown etiology may progress for a macroscopic metastasis. Biological differences of tumor cell metastatic bone disease inside the bone. Usually it's osteolytic, mainly via activation of osteoclast pathway. The tumor cell-induced chemokines, mainly interleukin-6, tumor growth factor beta, and interleukin-1, which stimulate the nuclear receptor kappa ligand and to be matched with the receptor over the osteoclast precursor to activate it into an active osteoclast. This is the pathway for the tumor cell to induce bone lysis, and less commonly is direct by osteoproteolytic enzymes. Osteoblastic property is mainly via cancer prostate, via endothelins. However, the sclerotic bone here lacks the mechanical property. It's not strong bone, it's a weak bone. So the clinical application is use of bisphosphonates or Frankel inhibitor. It's analog for receptor nuclear activated kappa ligand, which block the ligand to be matched with its receptor. So it's effective to inhibit bone lysis and to improve bone quality and induce more healing of bone. Bisphosphonates are two groups. The older group that lacks nitrogen component, it inhibits the osteoclastic activation and function, and the recent groups like Zometa, it included inside the osteoclast and inhibit its function. Biomechanically, metastatic bone disease, it acts either stress riser, like a drill hole, or open section. It reduces bone strength, particularly for torsional moment. Upper limb location is less expected to have weakness than in lower limb due to less mechanical loading. General causes of death, either by the tumor itself or tumor-induced paraneoplastic syndrome, metabolic emergencies, or thromboembolic complications, infection, sepsis. Clinical scenarios, the patient may present with a known history of primary cancer, and during follow-up, routine scan, it's positive. All have a generalized bony pains with or without known history of primary, or it may present with a pathologic fracture. The term pathologic fracture is fracture over an abnormal structure of a bone that affect its strength. It's not peculiar to metastatic or neoplastic disorders. Any bone disease that can lead to decreased bone quality may be called a pathologic fracture, either osteomyelitis, inflammatory conditions, dysplastic conditions, metabolic conditions, and neoplastic conditions. High index of suspicions is very important to suspect a pathologic fracture as a history of trivial trauma, pain preceding injury, known history of cancer, or symptoms suggestive of primary cancer. In X-ray evaluation, I should suspect pathologic fracture when I see an abnormal quality of bone, like here in osteopetrosis, or underlying lytic or plastic bone lesion, either solitary or multiple, or when I see an abnormal pattern of fracture, like transverse subtrochanteric fracture femur or avulsion of lesser trochanter. There are different clinical scenarios for pathologic fractures. First is a fracture over a benign looking lesion, like here over simple bone cyst, here over an incongruoma, here fibrous dysplasia with coxa vara, and here non-ossifying fibroma fracture. Second scenario is a pathologic fracture over an aggressive appearing solitary bone lesion suspecting sarcoma. So here, proper splinting and complete staging to reach diagnosis before intervention. The third is a pathologic fracture with a multiple bony lesions, like we see here, fracture proximal femur, fracture shaft femur with multiple lytic lesions. Differential diagnosis here, either metastatic bone disease, myeloproliferative disorder, myeloma or lymphoma, or metabolic bone disorders like hyperparathyroidism. So routine follow-up by clinical evaluation, history taking, thorough general examination or lymph nodes, neck examination, breast examination, chest, abdomen, PV, PR examination. Laboratory investigations here is to rule out other differential diagnoses like infection or metabolic disorders like hyperparathyroidism, and to exclude multiple myeloma by serum protein electrophoresis and immunofixation. CT chest, pelvis, and abdomen with contrast to evaluate for the primary cancer site. Bone scan, is the lesion is solitary or multiple, and local MRI over the whole bone with contrast. PET CT scan, if there is no economic compromise, it's a single study, and sensitivity more than the combined radiologic evaluation. It depends over glucose metabolism, and it's sensitive. Could differentiate benign from malignant neoplasms. Biopsy only for solitary bony lesions. In multiple bony lesions, I could go to reach diagnosis without need for biopsy. And the most of metastatic bone disease in biopsy will be an undifferentiated adenocarcinoma. The aim of management here in metastatic bone disease is mainly palliation. Palliation means the patient to be with better functional activity, minimal pain, better lifestyle, and in solitary metastatic bone disease, with proper control of the primary site, like in renal cell carcinoma, and maybe at aim of cure. It's a combination of different systems: orthopedic surgeon, medical oncology, radio diagnosis, and interventional radiology, pain management, physiotherapy, and nutritional and psychotherapy. Factors affecting decision-making in metastatic bone disease: first is the patient general condition, comorbidities, end-stage liver disease, end-stage renal disease, active cardiac failure that may affect the decision on the morbid surgery, primary carcinoma site. The better outcome is with thyroid cancer, followed by breast and prostate cancer, followed by renal, colorectal, and the poorer prognosis with metastatic sarcoma, lung, and melanoma. Metastatic bone disease alone or associated with visceral metastasis. Patient with metastatic cancer breast may survive for 2 to 3 years. However, presence of an associated lung and liver metastasis, it decreases survival to less than 6 months. So the non-operative management may have bisphosphonates to improve bone quality, radiotherapy, chemotherapy with medical oncology, hormonal treatment, splints, DVT prophylaxis, and better nutrition. The operative management here, the patient have to be stabilized well, proper evaluation for general condition, hemoglobin should be proper, platelet count, total leukocytic count, coagulation profile, serum albumin, serum metabolic profile, and in lesions with high vascularity, like renal cell carcinoma or liver, preoperative embolization is a must. Surgical options, either internal fixation or prosthetic replacement according to the bone stock, surgical resection in non-responder tumors like lung or renal cell or liver with massive bone destruction, or even amputation. In upper limb, in the proximal humerus, if good bone stock, I could go for curettage and fixation and cement. If poor bone stock, I will go for excision and spacer or endoprosthetic replacement. In the shaft, any method of fixation is documented, either plate fixation, intramedullary fixation, or even Nancy nail. The loading expected over the upper limb is not like in lower limb. Distal humerus, the only option is cement with intramedullary wires, flexible nails. No rule for plate for distal humerus in a pathologic fracture. In femur, proximal femur, there is no rule for side blade fixation for fixation of metastatic bone disease in the proximal femur. Failure is 100%. So in proper bone stock, I will go for intramedullary fixation by second generation nail. It's an active disease process. Soon or late, the peritrochanteric area will be affected. So first generation nail is contraindicated. The only is intramedullary fixation with long nail, second generation or third generation nail, if good bone stock, if poor bone stock for replacement, either by long stem or short stem, according to the bone stock, or even modular prosthesis. The question is to put cement or not to put cement inside the lesion. It depends over the bone stock, bone contact, and the primary carcinoma type. In patients which have a good response for other non-surgical treatment, hormonal treatment, radiotherapy, like cancer, breast, and the prostate, there is no need to go for bone cementing. However, in lesions like renal cell carcinoma, liver, or lung, bone cementing is important. Pelvis, injection acetabuloplasty, Harrington rods with acetabular reconstruction, or even saddle prosthesis. Spine, previously the main treatment was radiotherapy, but after invention of scoring system that may predict the overall survival, either Tokyo-Hashi or Tomita scoring system, to decide proper surgery, either to go for just decompression, posterior or circumferential, or just fixation, or en bloc spondylectomy and reconstruction. So the patient general condition, presence or absence of neurological compromise, presence of massive bone metastasis, presence of visceral metastasis or not, type of primary cancers, all these indicators for decision making. The value to go for prophylactic fixation in patients with metastatic bone disease is that better functional outcome, better mobilization, and better bone healing. The chondrogenic phase of bone healing is dramatically affected by radiotherapy. So the patient to be fixed before fracture is very important. Merrill put a scoring system to evaluate the bending option for fracture, site in upper limb score 1, lower limb score 2, and peritrochanteric score 3, pain in mild, moderate 2, severe by opioids 3, lesion is plastic score 1, mixed score 2, purely lytic score 3, and size. Score 7, the risk for pending fracture is less than 5%. In score 8, it's 15 to 20%. And score 9, it's over 30%. So in patients with Merrill criteria for score 9 or more, prophylactic fixation is important. Thank you.